Good morning and welcome to NeoConnect 2020. NeoConnect is NeoCon's online series of resources, programming, and events held throughout the month of June. I'm Monica DiBartolo, NeoCon's Director of Programming, and I want to thank you for joining us. Today's session is approved for 1 CEU credit for interior designers and 1 LU HSW for architects. It is also being recorded so you can access it on demand. Please refer to your screen for more details. So let's begin. Today's session is titled Healthcare Facilities Post-Pandemic, Programming and Design. Healthcare institutions, architects, and engineers reacted and adapted to the COVID-19 crisis, and their stories are being shared around the world. From converting existing facilities to building temporary solutions to an increased utilization of telehealth, we saw the vast unmet demand and the critical care needs of those affected by the pandemic. In this session, panelists will speak to what designers can do moving forward, while also looking at lessons learned from the facility adaptations during COVID-19. Our presenters include Douglas King, Principal Healthcare Practice at Stantec in Chicago, Illinois, Victoria Navarro, Regional Director of Planning, Design, and Construction at North Wisconsin Advocate Aurora Health in Milwaukee, Wisconsin, Camille Moretti, Senior Medical Planner and Vice President of HKS in Detroit, Michigan, Allison Fasher, Principal and Interior Designer at Smith Group in Boston, Massachusetts, and Roderick Walton, AIA Chicago Healthcare Knowledge Community Co-Chair and Associate Principal of Moody Nolan Architects in Chicago, Illinois. And now, I'm delighted to turn the program over to Douglas King.
Thank you very much, Monica. We'll just take a moment here to share the screen and dig up the PowerPoint. Oop. There we go. All right. So thank you all very much for I want to thank NeoCon, the AIA Chicago for facilitating this event. In particular, a big thanks to the AIA Chicago Healthcare Knowledge Community, specifically Holly Harris, Roderick Walton, and Julie Tolley for organizing and working behind the scenes to make this event possible. As an introduction, today's event is entitled Programming, it's basically Healthcare Facilities Post-Pandemic, Programming and Design Considerations for Healthcare Facilities in the Post-COVID-19 Era. We're excited to share our experiences, as many of our experiences are probably quite familiar to our audiences. And we want to be able to touch on how our involvement has evolved and evolved over the last several months. And we also want to include in our program some of the lessons learned and some of the risk assessments that we've applied as we begin to apply our knowledge to COVID response projects. Briefly, I'm going to ask each panelist to introduce themselves very briefly and explain and answer a question why they're here. We'll start with myself. I'm Douglas King, Principal at Stantec, which is a worldwide architecture engineering firm. We have many services besides buildings. My involvement in addressing the design and response to pandemic actually began in late February with an isolation hospital in the UAE, and then transformed to a major academic medical center and helped them with capacity analysis, and we were able to double their ICUs. And then lastly, I had the privilege of spending the month of April designing a 3,000-bed COVID facility at a Chicago McCormick Place. I'd like to turn this over now to each of the panelists to begin. Why don't we begin with Allison, and then we'll go to Camilla and Roderick.
Hi, I'm Allison Fasher, Principal and Interior Designer at Smith Group in the Boston office. I'm here because I've dedicated my career to healthcare interior design. And specifically, I've got a link to this through my participation in a Boston-based organization called the HAIO. And that is a group that formed several years ago with the mission of eradicating healthcare-associated infections. And we had been deep into that process. There were about 30 of us participating in that when COVID-19 started to surge. And so that group turned its focus to study of alternative care sites. And that group of A&D, hospital leadership, project managers, and contractors grew from about 30 to about 100 volunteers studying that deeply. So we moved on to next phases of reopening. So that's my
Thank you
blurb.
very much, Allison.
Sure.
Camilla, take it away.
Well, thank you everyone for attending today. I'm Camille Moretti. I'm a Vice President and Healthcare Planner at HKS. I'm Director of Planning for our Midwest region. And the reason I am here is I also, as Doug has mentioned, participated on the design of a 1,100 bed hospital, or COVID temporary hospital in very close to home, less than a mile away from my personal home. And applying what we learned with that into our projects on the board, and really forecasting the impact of COVID in any future pandemics to what our long-lasting project impact. So that's why I'm very excited to speak with this team today and share this with all of you.
Thank you, Camilla. Victoria, you're up, and then we'll have Roderick.
Okay. Hi, everybody. Thank you for having me. I am excited to be on this distinguished panel and share my experience as the Director of Planning, Design, and Construction for Advocate Aurora Health with our pandemic response, our surge management, and our pathway to reactivation. So I'll be happy to share that experience during this unprecedented crisis.
Thank you. And Roderick.
Hi, and good morning, everyone. My name is Roderick Walton, and I'm a co-chair for the AIA Chicago Healthcare Knowledge Community. And our knowledge community is committed to providing educational opportunities that showcase our industry's thought leaders. And so I'm absolutely thrilled today that we have an opportunity to assemble the panel that's here. These are industry experts who you see before you today, and they represent a broad and diverse spectrum of our healthcare delivery practitioners and stakeholders. So we're just thrilled and elated that they volunteered their time to join us today. My role today will be to facilitate the question and answer session at the end of the discussion.
Thank you, Roderick. And now we'll go to the learning objectives. As Monica pointed out, this has AIACUs, and we have four big ideas here, starting with the big idea, which will be establishment of goals for programming in a pandemic scenario, or what are the criteria as we move beyond the immediate crisis. Second will be engagement of the stakeholders early in the programming process. How do we use that criteria? How do we frame issues? Third will be describing and addressing common programming design and operational issues, both pre-vaccine and post-vaccine, as we design for a more permanent installation. And lastly, and the exciting part for me, is the build up to the lessons learned. What are the lasting legacy of this entire experience for each of us? We have taken and applied a lens to this entire issue. We have actually three basic lenses that we're looking at. And we did this because, frankly, there's different activities at each of these points. I was moved by an article that Bill Gates wrote in Economist magazine recently, where he made an analogy to World War II with this issue, saying that we're in about 1942 right now. And that obviously we have a way to go. We're engaged in battle, but we haven't quite developed the weapons yet, or the processes and the strategic approaches. So we have the immediate crisis, which we call day zero, which is all too familiar. For many of us, that meant it's probably the month of March and possibly April. We then turn into, we'll discuss day one, reopening pre-vaccine, which is kind of the period we're in now. And then lastly, we want to talk more on the legacy. Without further ado, I want to turn this over to Victoria Navarro at Advocate Aurora to talk a little bit, or to explain in a bigger picture view, some of the things that they've been doing as a model for all healthcare facilities around the world, frankly.
Thank you, Doug, and thanks again to AIA Chicago Healthcare Knowledge Community, NeoCon, and NeoConnect. Again, my name is Victoria Navarro. I am Director of Planning and Design and Construction for Advocate Aurora Health. Today, our thoughts are with all the patients and families who are impacted by this heartbreaking crisis, our physicians, our nurses, and team members who continue their unwavering commitment to care for our patients and each other. As we started last month, today, June 19th at 10:19 a.m., Advocate Aurora Health team members will pause for 19 seconds to honor those who have lost their lives since COVID began, all those who continue to battle, and our team members who've worked so valiantly to restore health for all. Given today's date falls on Juneteenth, the celebration of complete emancipation across the nation, we will also pause at the same time to recognize the fight for equality and justice. Advocate Aurora Health is known for our track record in clinical quality and outcomes. Our enhanced scale and expanded access brings us greater efficiencies and a network to scale innovation. We have reshaped access by offering more sites of care in the Midwest and created a destination for patients, talented clinicians who care for them. We have reshaped our access by using the latest technologies to deliver care to patients exactly where they are and exactly where they need it. One shared purpose brought us together, and that is we help people live well. We are a consumer-centric system that improves the quality of life for the diverse communities we serve in Illinois and Wisconsin. Now, as the 10th largest not-for-profit integrated health system in the United States, our combined strength and stability drives us forward. Caring for nearly 3 million people has inspired a transformation of care delivery across 28 hospitals, more than 500 sites of care, where we employ more than 3,500 physicians and 70,000 team members. In March, we began our surge planning, and we started by opening up a temporary driving test center for patients who've been experiencing minor or mild symptoms and didn't require hospital evaluation. At that time, we were also setting up our hotline so that we could help triage and better manage patient flow and prevent exposure. This was all important in the early stages of our surge planning so that we could help prepare for this pandemic. And what we also did in March was take a look at our elective surgeries and procedures, and we put those on pause. And that was throughout the duration, and we've just now started to reactivate. But earlier in the start of the pandemic, we began to message that the gatherings of 10 people or greater needed to be paused. We talked about the supply chain and personal protective equipment that were becoming in short supply. So as there continued to be a shortage of test kits and the materials needed, we began to share protocols with the Illinois and Wisconsin Hospital Association to determine new testing protocols and to conserve those tests for those critical in need. We also began routine care with scheduled video visits, and that was to, again, minimize that interface at the hospital sites. We also began our test processing within our own ACL laboratories, which is part of Advocate Aurora Health, to process these COVID-19 tests. And these were for our patients that were ED patients authorized for inpatient admission, team members authorized for testing by employee health, and that continued. And we also broadened our team member screening for all team members, physicians, and contractors at the start of every shift and in alignment with the CDC and state guidelines. Around the later part of March, our governors sent a clear message in Illinois and Wisconsin to do their part to stop the spread of the virus. And we wanted to encourage embracing social distancing and continue to make everyone's family, relatives, their neighbors, and communities safe. And most importantly, to help the doctors and nurses across a time when we needed all of their help. And I remember that we began our planning for the Overflow tents, and we set up these tents next to the ED, and we did this in a very systematic fashion, a lean fashion that was organized through our Central Surge Ops Command. And this helped all the hospitals across the Advocate Aurora footprint. This was part of our proactive preparation for a surge volume of patients who presented in the ED with mild COVID symptoms. They weren't testing locations, but they did allow for greater protection of our team members and patients by separating the suspected COVID patients and not bringing them into the main hospital unless they required further treatment after their screening. The tents also help to efficiently conserve personal protective equipment as they're designed in a way so that staffing is kept to a minimum. We also continued with our no visitor policy. And then we also were impacted greatly because given the uncertainty and changing dynamics during that pandemic time frame, the capital projects across the entire Advocate Aurora Health system were being reevaluated and routine capital expenditures were halted as a result of the significant increased operating expenses and lost revenues. So we focused on continuing to battle COVID-19, and we directed our capital and operating investments to achieve this objective. During this time of reevaluation, construction projects continued with the exception of renovation work in existing hospital facilities to prevent the spread of infection. Where construction was ongoing, we instructed general contractors to ensure workers practice social distancing, universal masking, and hand hygiene. And then we also looked at projects where we needed to pause. So as I mentioned, the surge management plan was used because when a hospital's patient volume has reached the point of overcapacity, this required the hospital to use a unique process to manage the heightened number of patients that we experienced with the pandemic. Every aspect of a healthcare organization is stretched when responding to an unprecedented event, from the people to the processes, supplies, and facilities. And implementing a strategic response plan through lean methodologies helped our organization take on the most complex challenges. At its core, lean is a business methodology that promotes the flow of value to the customer through two guiding tenets: continuous improvement and respect for people. Our lean approach to surge planning included creating a system surge ops command and site incident commands. We established daily management plans, we mobilized our resources, and we formed workflows for communication, data, infection prevention, finance, human resources, and health information technology. This increased the pathways of information to ensure responsible decision-making and creating those service lines to our customers.
Thank you very much, Victoria, for a very thorough and inspiring story of Advocate Aurora. I'd like to turn our attention now to the challenges, considerations, and opportunities presented through day one as we call the reopening and pre-vaccine era. Allison Fasher, a principal and interior designer with Smith Group, is going to share her experiences as we transition from this temporal phase 0 to the current now. Thank you. Take it away, Allison.
Okay. So we've been doing a lot of learning. I think we've all been doing a lot of learning as this pandemic has gone on. And we have been studying the healthcare environment at every touch point. So on using the interdisciplinary team that we have been putting together a series of recommendations on the new normal for healthcare, both as we start to work from phase 0 to the next phase, which is the reopening. Because this is requiring a rethinking of flow of operations and modifications at every touch point on that patient journey that we all work on a day-to-day basis. So I thought it would be interesting to just take a look at that path. and the various considerations that we know need to happen along that way. And I think the first important consideration is communications. So as people are starting to now re-enter the hospital, the path, the way that they get there is going to be different. And so having really clear communication about the expectations, what's different, taking care virtually of what you can before arrival, clearing the interactions that might typically happen at a greeting point and culling those down to minimize time is important. And then things as mundane as you're coming to a different entry, calming fears about how the valet process, if there is one, might be different. And communicating expectations on the role that patients play as they arrive, the expectation of masks, for example. As we progress to an entry point, some of these may be easy pickups to do now, some of these may actually slide to future state. But we're all feeling a little bit squeamish about touching shared surfaces. So thinking about hardware and eliminating points of touch as people make their way through facilities is important. We heard from Victoria that screening and triage space is already in place. I'm sure that's going to be in place for some time. But having PPE available to people as they enter, segregation of sick and well. And as people are starting to move into the facilities more regularly, evaluating all streams of patient visits, looking at collision points, and managing that flow of traffic to keep circulation clear is going to be important. The other piece of this is the fear that comes with the reentry. And so part of this is just being visible with the cleaning protocols and again, communicating the protocols that are in place to keep people safe. If you have a waiting area at this point, I think there's a number of interventions that need to happen for that area. And one of them might be that your process has changed and people are now self-rooming as they make their way from curbside to treatment. If you are maintaining a waiting area, we're certainly working on breaking that into smaller areas and isolating. We've been using a disto software program that actually quickly generates socially distant plans and communicates safe seating locations. In waiting areas, also careful use of transparent panels. I'm sure they're gone already for our clients, but eliminating shared items such as brochures and magazines at this point, that's a no-go. And being more flexible in the way those rooms are set up. So we really need to be flexible and be able to move things readily. With all of the cleaning protocols that are now set and in place, I think we need to review finishes that are currently in place against these updated disinfection protocols and make sure that any new selections that we're making are going to stand up to this increased rigor that we did not have in place literally last year. There's certainly considerations facility-wide for MEP and enhanced filtration. And as your patients are moving from waiting to treatment, we are still we still know that family is not being allowed in with them. So I think it would be important to find a vehicle for inclusion of family for that support and making that a bigger part of the visit, because that's an important piece for patient experience and again for allaying fears and basic communication protocols depending on who's being seen.
Thank you very much. Go ahead, sorry.
Oh, sure. I was just going to say, we're currently working on all of these interventions. So we're in the process of reviewing our projects against these and generating plans, calling out PPE, graphics, flow diagrams, updated furniture plans that are safe, location plans, and doing finish and hardware reviews and MEP reviews. So that's kind of where we are right now.
That's great. I think a lot of firms, I know Stantec and the firms represented here are doing, are preparing guidance documents for their clients and for public use. And I think we've got, there's many checklists, much material out there that's being developed to help with this. Allison, I'd like your overview that you gave as to how we deal with the world now. Question on the table might be, well, what about the projects that are on the boards? What are we doing as we move ahead into perhaps the new normal, or we are opening new projects? Fortunately, we have Camille Moretti, a senior medical planner with HKS, to lift up what some of these immediate impacts are on these projects, including process improvements and other aspects. Take it away, Camilla.
Thanks, Doug. Yeah, Allison pointed out a lot of really good points that we have been encountering with our projects. We have, projects on the boards. We have projects that are finishing construction, and some of that actually paused a little bit on the substantial completion to incorporate certain aspects that will help them get their infrastructure a little more robust to accommodate or to respond to a future pandemic. I think if I may highlight, the biggest things are registration, interaction of how do I get the patient, that flow of the patient from outside into where they need to go without having as many stops as we have now. A lot of our clients had to do this, and there had been conversations for years and years, and they were able to operationalize that in a month because they had to. So I think there's a lot of things we're learning, that how we can leverage technology and improve our processes to get that from point A to point B, or where we want to go with the patient. That journey needs to be rethought, and registration is a big point. The other, is the idea of waiting. We, as process improvement, at lean thinking, we're trying to eliminate waiting. Waiting is non-productive time. So how can we really rethink processes to help our systems eliminate that, and maybe create, instead of waiting rooms, maybe those are pods that you have an opportunity to pause somewhere, but it's not a full waiting room. We have to stop thinking about creating that queue so that I have, I'm sure that the patient is there when I need the patient to be there. There are other ways that we can think about improving that. And then finally, there's a lot of mechanical concerns or opportunities to really build in that infrastructure. We had a lot of our hospitals rebalancing their units, creating temporary, anti-rooms and negative pressure anti-rooms outside of positive rooms. So you're protecting the patient in an OR, but also protecting the staff and the rest of the building to really exhausting all of that air. We have a project on the boards right now that paused construction or the finishing of construction to install extra exhaust fans and rebalance some of the rooms to have that ability to provide care for a patient that might be, COVID positive. So I think that, we're looking at all of our projects on the boards now earlier in design. We do have a big opportunity to have an impact for what's coming next. What is the new normal? How are we addressing that new normal? What is the legacy? So I think the biggest points that I could say is, making sure that we can plan for business continuity. I think Victoria touched in a great point that the business of healthcare was put on pause. All of your electives were put on pause, and there's that level of trust going back to the healthcare environment that patients are very conscious about, and making sure that we can address a pandemic and still maintain that level of continuity with other health services. So that is, I think, the biggest point that I can make to this team is we need to build resiliency, and we need to be able to separate. We need to be able to create a way, flows within the hospital, our different lines of defenses to prevent that level of fear that you would have as going in for your well visit, if you needed to go in versus a virtual visit, that you're not questioning that because you might contract COVID. The one big point I would like to make is the emergency room, emergency department design is going to change dramatically, and we're seeing that with a project that we have on the boards currently. That the tents are great, but it doesn't. Our team wanted to protect staff as well as protecting the patients, allow their staff to feel safe and still be able to triage patients and show them the right way or the right flow to take before entering the building. So we're looking at, triage vestibules where you are checking the patient before they enter the building and, directing them either to a respiratory waiting zone versus a non-respiratory waiting zone. And those can be divided and both negative pressure so that you're reducing the chances of cross-contamination between your regular business and your pandemic capacity. So the thing that we really need to think about in future planning of the new normal is that how do I activate that pandemic mode? What is that easy button that I can still maintain the flexibility of the surge capacity, my MEP capabilities, but not lose business continuity. I think that's the biggest point that our clients are really concerned with, and we're helping them through understanding what has to be there, what is pandemic mode, and what is future flexibility for that one space, for example.
That's fantastic. Camilla and Allison, thank you for sharing on these aspects. Camilla, I'd like to build upon the legacy which you began to touch on and ask either Allison, Victoria, or perhaps myself even, to weigh in on some other thoughts that might be on our minds as we move towards what's the lessons that we carry forth and what we think we're going to be applying as we do the permanent projects in the future. So either Victoria or Allison, feel free to jump in here.
I can start. So really, I think the ability to reactivate our plan is going to help stabilize our organization culturally, operationally, and financially. And we need to recover and transition to our new normal. So embracing that transformation, building it into our organizational DA, enhancing that patient experience, and increasing access, improving clinical outcomes for all of our patients and families is going to be the goal. We need to reinvent our operations and care delivery by continuing to systemize our decision-making and execution within the clinical operations and adapting and leveraging that technology to address how we're going to recover from the financial constraints. In the hospital setting, I think by refining our inpatient cohorting plans, both COVID and non-COVID, will help to optimize our flows and evaluate our staffing models. We will also be able to reset the lessons learned and evaluate reconfigurations and transitions in that inpatient setting. Streamline testing, supplies, clinical protocols, as well as the impact of critical care, the ER, anesthesia, and nursing professions are all going to be really studied and again, reinvented to optimize. Our surgical and procedural service lines and program distributions will need to really take a look at those block utilization scheduling, the prioritization of deferred procedures. We're going to be focusing on provision of access and capacity again, and the input of general surgery, cardiovascular, GI. Also in the ambulatory setting, there will be a broader variety of access and increased convenience, technology-enabled disease management, virtual specialty care offerings, and self-service diagnostics. We're doing all kinds of evaluation and consolidation of our smaller sites, so it's greatly impacting our footprint and real estate square footage. And then the input of medical specialties and primary care professionals are going to be key here, as well as at the health at home and all of our support services. All those protocols, systemized supply chain and food delivery services, all of that is exploring innovative solutions.
Thank you very much, Victoria. Several thoughts on the legacy of this pandemic. One of the things I'm moved by is how quickly virtual medicine became a tool for our healthcare providers. I'm on the board of an FQHC called Heartland Health here in Chicago, and they see about 110,000 patients a year, all living below the poverty level, and they were able to recapture over 80% of their patient load through virtual medicine here in the last several months. And I know that they're probably not alone in that endeavor. So that, do any of the panelists have thoughts on what might happen in the hospital as perhaps VM starts to be a regular gig? Camille,
I'll tell you that we actually been having a lot of conversations about telemedicine, and our data shows that there was a peak about 4 weeks after the start of the quarantine across the country, where there has been that huge adoption, because that was the only option. And we're now seeing that as states starts to reopen and systems start to open up, that has come down a bit. So that curve has peaked, and we're seeing a gradual downward trajectory. What we're seeing though is that a lot of our systems are now looking at what are the right things to keep in virtual. There are some really positive attributes for that. So a post-operative appointment where I would have to drive maybe half an hour to an hour to see my physician for 5 minutes. And I wouldn't be able to have somebody with me because they can't take the time. Well, we're seeing a lot of people now have their significant others or a caregiver that now can attend those because it's so convenient, and be able to create that that continuum into the home a lot smoother. So we're seeing it not only those types of visits, but maybe certain things that are not required to have a face-to-face completely shifting into that virtual only. So what we're seeing in the boards is, how do I address that in my clinic? Does that mean I need less number of exam rooms or a different type of exam room? We also need to address with the disparity, I might not have a connectivity to that. So what happens if I, as a system, set up a room for virtual visits on my campus that not only can connect my patients to experts around the globe, but connect to patients that might not have access to that in their home. So we're looking at two types of spaces. The virtual exam room, physician is on campus and patient is elsewhere, and where the patient is on campus and physician is elsewhere. So that really opens up a lot of possibilities. And, through the use of technology, we can really expand our reach to the communities, to different communities. So the whole idea of market share is going to be flipped on its head, because there is no more physical boundary that we can definitely break through that and use what we learn in pandemic mode and apply to that moving forward.
Thank you, Matt, very much, Camille. Use the term disparity. I wanted to touch on that subject because it's a cousin in a way to virtual medicine. And one of the things that gets addressed is it starts to equalize access to health, as you identified. And it's a subject that, of course, is near and dear to me. I've had the opportunity to lecture across the country on this subject, and in fact shared the stage with Victoria Navarro almost 1 year ago on this. And I'm curious if, Victoria, you have any thoughts on the subject of disparity of health and how this has been raised, and the subject of racism as it's been raised through this whole pandemic.
Yeah, absolutely. I think we need to acknowledge that this nation is faced not only with one, but two pandemics, one being what we've been battling with the COVID-19, and the other, unfortunately, since our nation was formed. And I think our commitment as an organization to diversity and inclusion has never been more important. Individuals of diverse backgrounds and cultures are a valued part of our organization and the communities that we serve. We deplore racism in any form, and the work we do is intended really to confront it and help bring it to an end. That good work is founded really in our values of excellence, compassion, and respect to help people live well. And I think at a moment in this time when there's a racial divide in our country, I'm really hopeful to see more people acknowledging, especially today, how Juneteenth plays in demonstrating how we can overcome oppressive systems, oppressive structures, and institutions. And despite the hardship and pain that we've seen over the last few months, we're now at an unprecedented moment in our country for opportunity and really to advance a broader array of health, social, and economic policies that lift up communities of color. And this result will be a better and stronger community for everyone. So I really hope that we can focus on things like diversifying our workforce, because, our health for everyone can only happen with culturally competent workforce. And you need to be engaged and include people within our communities. Also, we're taking a look at recruiting with a racial lens and investing in community job programs. And I think a lot of that, Doug, is what we talked about with population health.
You're on mute.
I'm sorry. Yeah. I unmute myself, guys? Yes,
we can hear you.
Good. Yeah, there's four buckets, and I just to touch for a minute on this. Over 401 years, it's been through racism, we've created a situation where there's been a lack of healthcare access. That is identified now, and I think we need to improve that access. We also need to provide that opportunity that you talked about, both in jobs and opportunity for advancement in education to eradicate poverty. Poverty actually results in situations where people are working at, positions that expose them at the front lines. A lot of service jobs that are placing those individuals at risk, both in their jobs and also through transportation. And the last one I wanted to lift up is one that's emerging. There's been shown a linkage between, interesting enough, environmental pollution, particularly air pollution, and the growth of coronavirus. It appears that the particles in air pollution are a ready-made mechanism to carry COVID to people's lungs. And we need to work on that. We need to understand the environment is at play here as well. So I want to ask if there's any other comments as we close in the presentation. Any other folks on our panel want to interject?
We are at Smith Group. We're actually in the process of forming a national justice committee. So we are looking to do more, and we're still evolving it, but we will have a focus on mentorship, on community outreach. We want to more deeply look into serving communities in need in the work that we do, and look for opportunities in every project and every opportunity that we're working on. So that's ongoing with us, and I thought I'd mention it.
Yeah, at HCAS, we also have a justice, equity, diversity, and inclusion team, the JEDI team, that has, we've been working with community development, and we have programs called Citizen HKS, and every year we have a certain amount of projects that get submitted to really try to help a little bit on that divide, and try to reach out into our communities, and that is also part of our JEDI program. And we've been talking about this. There's no we're gonna grow. We're gonna try to be better. No one is there yet, and that's the whole point of this, is that we're slowly getting to that first step of recognizing and understanding. And we're all, I think, as a community, as a design community, trying to see what are the right answers, how can we implement that, and how can we make sure that it's maintained, that it's not just, like at the peak here, that we continue to grow and really eliminate the disparities that we have, especially within our profession, that is very homogeneous, unfortunately.
Thank you very much, Camille. I agree. In fact, I want to pick up on what Allison said as we close here. Allison brought up in her first sentence, she talked about communication. And I think one of the things that is our lasting legacy is the communication that occurs between hospitals and with our overall community on the issues that have arisen during this pandemic. I know I'm speaking on behalf of the committee. We'd welcome continued conversation with the attendees. We're going to open it up here momentarily for a Q&A session moderated with the help of Roderick Walton. But we just really want to underscore how exciting and how much fun this has been to put this presentation together. And I've learned so much from fellow panelists and the organizers. So thank you all very much. Roderick, do we have any questions?
Thanks, Doug. And on behalf of the AIA Chicago Healthcare Knowledge Community, I want to thank all the panelists. What an engaging conversation that we had. I hope our listeners and viewers have learned a lot and that they can apply it to their daily practice. We do have a couple of questions that we'd like to pose to the team. The first one has to do with social distancing. And so the question is about the technology being utilized to facilitate social distancing inside the clinical environment. Does anyone have any insights on the types of technology or software that's available to help promote social distancing inside the clinical environment?
Yeah, I'd like to go ahead. Yeah, someone grab that one.
Okay, we have one that was actually, we developed in-house. So our IT group, TIP group, developed something called Disto that works with, it's an add-on to the Revit model, and it actually, once you tag the seating, you can start to generate multiple iterations of socially distant diagrams. And you can deselect and it will learn and it will generate the next. So that's been really helpful.
Yeah, we created the same thing within HKS. Our team has been testing all of our, as we reopen our offices to identify, graphically where are the concern points and how can we address that. And we've been slowly applying that to our clients' waiting rooms as well in all of those spaces. But we've been testing it in-house with our tool, and it's fantastic to see how close we went from, the bench seating offices to now everyone wants to put walls between them. So I think not only in the transition that our healthcare clients are having, is our own offices are going to be transformed, and how we come back to work.
It's amazing how much in a hospital is administrative and people, this has to be taken into consideration. Roderick, what's the next one?
We have another question for the panelists. How will families be able to visit their loved ones in the new environment? Will there be enhanced wayfinding opportunities? Will there be separate lobbies for families to visit their loved ones? Or what's the strategy for that moving forward?
Wondering, Victoria, has Advocate Aurora addressed this issue or begun to think about how this might be addressed?
I think, again, we're thinking with COVID infected patients, we leverage technology. So whether it's through distributing iPads and allowing families to communicate with their loved one that was in a patient room, that is going to be continued to be leveraged. And then again, through our digital patient engagement at the footwall of a patient room, the TV and the monitors, I think it's going to be enhanced even further to see how we could really optimize technology for that purpose.
Anyone else have a quick tidbit on this? Or we move to the next question?
Okay, here's the next question. What code compliance requirements do you anticipate changing as a result of the pandemic? Do you think that there will be larger public corridors, for example, or other code compliance metrics that will be introduced?
I'm going to actually take that one just for a moment to do a little community education here in terms of what's going on with the FDI guidelines. Recently, a group of folks, including myself and others, have been assigned to create the pandemic response. We're creating white papers, and we're creating basically lessons learned and addressing issues such as this one right here, Roderick, in this work effort that'll be going on probably over the next 8 or 9 months. But I'd be very interested if any of the other panelists have contributions and thoughts that have come to mind.
I actually had a conversation yesterday with a state official from one of our projects that our clients are requesting more isolation rooms, the ability of having more isolation rooms. And, there's a big difference between negative pressure and isolation with all of the door alarms and everything. And the issue is that when you do isolation rooms, you're required to have a dedicated toilet room with them. And and then also there is the whole point of, are we looking at now bringing back ante rooms? They're not required currently, but it is a good idea. And if we are looking at ante rooms, should we also be looking at doffing rooms? So you have a unidirectional flow. So for high infectious disease suites, I think there will be a new portion of the guidelines that will require you to have unidirectional flow. You have a donning room and a doffing room that's attached to that exam room or a patient room, like we saw back in Ebola time. We have designed a few of those, and there's a lot of facility impact that if considered early, you can't retrofit. So those are some of the things that I believe we need to, will be making a big impact on the code coming up.
Sure. And I'd like to do a shout out to the ASHRAE folks who have developed a directive for future impacts on HVAC systems. Camille, you mentioned the ante room, and actually the whole HVAC design world is certainly rethinking how air gets delivered, particularly in a healthcare setting. And I would direct anybody who's maybe a technical geek like myself to reading this white paper put out by ASHRAE on this issue, because it's going to be groundbreaking.
I think if I may say one thing is that we all know that our procedure rooms have to be positive pressure. ORs need to be positive pressure, but we also need to think about how do we operate on patients that might be, might be positive, and that might just be, how do we operate on TB patients? We need to be able to have that infrastructure in place that it could be an easy tweak, or activating a separate door that has an anteroom and sealing off another door, so that you're building that flexibility in your system, in your hospital. Because we can't build our churches for Easter Sunday. We can't build our hospitals for pandemic mode, but we also need to be able to maintain our operations during a pandemic. So the point here is thinking through what are our flex spaces? How do we activate the flex spaces to really have that seamless activation of non-pandemic to pandemic mode?
Yeah.
Victoria wanted to jump in here.
Yeah, I was just going to echo, Camilla, what you were saying. That is exactly what we experienced. We had laboring mothers that were infected with COVID and couldn't take them into the C-section if they needed a C-section. So we're looking at how to adapt our labor and delivery rooms to have surgical lights or the medical gases to do a C-section. Or do those rooms warrant an anteroom? Same with looking back at the ward scenario, a COVID unit that is all negative air pressurized, and how we can separate that from the rest of the unit and the corridor that it's adjacent to. So those are real problems, and we had to do it because it was emergency mode, but it's really taking a look at that adaptability and being able to flex in those situations.
And I would like to just say there's more to come on this issue. We're taking part with Clemson in an OR research project on this very subject of how do we do patient care in this current pandemic environment. Roderick, is there any last questions that we might be able to entertain?
I think we have time for one more question before we wrap, and it has to do with the interior clinical environment and interior finishes, flooring, carpets, wall coverings. Will they have to be antimicrobial, or what do we think the lasting impact will be in terms of interior finishes in the clinical environment?
I'm going to take a wild guess and say that Allison is probably the best.
That's probably me. I think we do need to take a careful look at putting in place materials that are easy to clean, and looking at the time that's also dedicated to cleaning. So I think we need to be mindful of reducing cleaning times across each area. And that in itself makes for a cleaner facility. So less transitions and less fussiness in the detailings will make it an area easy to maintain, and then easier to be antimicrobial inherently. But I'm not supportive of added chemicals as a vehicle to get there. So I think we need to look carefully and use healthy materials that are inherently not able to support growth of organisms.
Excellent. Roderick, thank you very much for assisting on the Q&A portions. I want to thank the panel for the privilege to be your moderator and to take part. You guys are great, and I actually will miss our practices and our conversations. At this point, I'd like to turn it back over to Monica Bartolo to close us out. Thank you.
Well, thank you, Doug, Allison, Victoria, Camilla, and Roderick. That was a very thorough and thoughtful presentation and a great conversation. We really appreciate you sharing your expertise with us. So thank you. And thank you to everyone for joining us today. Please be sure to join us next week for the continued series of webinars during NeoConnect 2020. Have a great weekend and be well. Bye-bye.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Bye now.